Hi there and welcome. My name is Dr. Marlena Jabara, and I'm the proud founder of RadPodSquad. The RadPodSquad Fellowship offers an immersive learning experience tailored specifically to podiatric imaging. RadPodSquad combines comprehensive curricula, cutting-edge techniques, and on-demand access to training that will provide you with the new knowledge and skills that you need to boost your confidence in imaging and truly make a difference in treating your patients. Check us out today, radpodsquad.com. Now let's take a look and move to the axial plane. So on this schematic, we can appreciate we've removed the tibia and the fibula. We're moving down to the region of the talus. We can understand the articulation along the medial column between the talonavicular and the lateral column. And we can see almost everything we're going to need to see on axial imaging. We can see our extensor tendons anteriorly. Remember that the tibialis anterior is about equal in size to the posterior tibial tendon. We have our extensor hallucis, the extensor digitorum, and peroneus tertius. Remember, our deep peroneal nerve lives underneath the region of the superior extensor retinaculum. We have our medial flexor tendons, the posterior tibial, flexor digitorum, and flexor hallucis longus tendons with the nerve artery vein bundle. Again, we have our lateral flexor tendons where we see the brevis in front of the longus against the distal fibula with a superior perineal retinaculum. And of course, we have our Achilles. If it's normal, it's going to either have a flat ventral surface or a smiley face. And we see our plantaris, again, noted medially inserting. Looking at our anatomy and search pattern for the axial images, this is our major search pattern and workhorse. We're going to be looking at the medial flexor tendons, the PT, flexor digitorum, and flexor hallucis. We're going to be looking at our lateral flexor tendons, the brevis, the longus. We're going to look at our extensor tendons, the tibialis anterior, extensor hallucis, and the digitorum tendons. We'll be assessing our ligament patterns. In this case, there's just a slice through the anterior talofibular and posterior talofibular ligaments, but we'll be able to see the syndesmosis and all of the intervening ligaments. We'll be able to assess portions of the deep deltoid, the spring ligament, and portions of the supromedial band of the spring ligament and superficial deltoid. We'll, of course, assess portions of the Achilles and the plantaris and the bony structures. So in the assessment of a normal MRI, the first thing we can do is take a look at what information we can glean from each of the sequences. So not only is the sequence structure comprised of the different signal intensities, but also the planes that they're in. So let's take a look at what anatomy we can see best first on an axial image. So I've loaded up the axial image, that's the orthogonal plane to the tibia and the fibula, and we can see that as we travel along the coronal plane, it's showing us what slice we're at what level we're at. So we'll travel with that. So in looking at the axial image, and I'm just going to bring that up as a single view right now, starting from the superior proximal to distal, let's just take a look at breaking down the posterior tibial tendon and the medial flexor tendon group. So when we begin, we can understand that there will be a flexor retinaculum that binds all of the tendons to the region of the tibia. So that's the first thing we encounter is our medial flexor retinaculum. And we can then see our posterior tibial tendon, which is seen in this case almost twice the size as the flexor digitorum longus in this 13-year-old patient. So posterior tibial tendon, we can travel down. We can notice that there's a small sliver of fluid, which can be a normal finding. We will call tenosynovitis when it surrounds the tendon completely. We can see the fibers of the posterior tibial tendon partially insert normally on the medial navicula, and then the remaining will insert on the basis of the cuneiforms and the basis of the metatarsals. So we can appreciate the posterior tibial tendon seen here, and then the flexor digitorum and the flexor hallucis longus on axial image. So we can see that the flexor dig and the flexor hallucis longus will travel together to a place called Henry's knot. And I'll bring back the coronal image to show us where we are. So right now we're looking at our posterior tibial tendon, the flexor dig and the flexor hallucis, and they're going to cross at a location called the master knot of Henry. And we'll be able to define that space just in case there's tenosynovitis. Now, one other thing that we can appreciate on the medial side is that we have the tarsal tunnel contents of the posterior tibial nerve, artery, and vein in between the flexor digitorum and the flexor hallucis longus tendons. And this nerve artery vein bundle travels along the posteromedial ankle through a fibroosseous tunnel to then decussate along a place called the porta pedis. The porta pedis is a place where the nerves, arteries, and veins will decussate, first giving off the medial plantar branch and then the lateral plantar branch. And of course, the medial calcaneal branch was the first branch given off. So the tarsal tunnel is that space. And one of the things we'll be always looking for in this region are the presence of accessory muscles. And one of the sequences that can make it easier to see that is when we have a T1 weighted sequence, which we have here. And we can appreciate now on a T1 weighted sequence in the different type of signal intensity where we're leaning towards the fat signal intensity, that can help us outline the anatomic contents of a compartment. And that's what we see here. Between the flexor digitorum and the flexor hallucis longus, we have our nerve artery vein bundle. This is the nerve here. And we can see the posterior tibial nerve, artery, and vein coming through its space and then coming along again, the porta pedis. That's going to be a space between the quadratus plantae muscle here, the abductor hallucis muscle here, the flexor digitorum brevis muscle there. So we'll be looking for the region of any kind of mass or compression in this region. In this case, we have an accessory muscle, here's a small tendon, and this is a flexor digitorum accessory longus. It's going to then attach to the branches near the quadratus plantae and travel along to provide support for the plantar aspect of the foot. It can create a feeling of claudication and fullness of a patient who may present with fullness in the ankle. Moving back to our T2 or fluid sensitive sequence, we can now move from the medial flexor tendons where we've seen our posterior tibial, flexor dig, flexor hallucis, nerve artery and vein, and the flexor retinaculum. A lot of anatomy, right? Moving on to the peroneal tendons. Now, the peroneal tendons, we have the peroneus brevis, which is this nice S-shaped structure, sort of the eyebrow between the peroneus longus dorsally and the dorsal aspect of the retromalleolar lateral groove. So that's the brevis in front of the longus to protect the longus, which is a more round tendon. The brevis is actually a flat tendon. It can come in different types of variations. There can be two muscle bellies. There can be accessory muscles. In fact, the peroneus quartus, as we mentioned, is the most common accessory muscle of the ankle. The accessory quartus, when present, will attach to the lateral border of the calcaneus. And in this case, we're seeing also bands of the superior peroneal retinaculum. So this is the ligamentous portion. And then there's a labral-like fibrous ridge seen here that prevents resistance to the peroneal tendons from subluxing laterally, which is a very common pathology. The peroneus brevis we can see on the axial image along the inframalleolar groove. That's the location just after the lateral malleolus to the base of the fifth metatarsal where it will attach. And of course, we can see the peroneus longus will move on to go at the undersurface of the cuboid tunnel. So there's a lot of anatomy seen on axial image. Let's move to the extensor tendons, the tibialis anterior. We're going to assess the tibialis anterior based on its size in relation to the posterior tibial. They're usually about the same size. Then we have our extensor hallucis and our extensor digitorum tendons, peroneus tertius coming most laterally. In addition, we have extensor retinacula holding the extensor tendons to the region of the tibia, the superior extensor retinaculum, and also the inferior extensor retinaculum seen here. We also can appreciate the anterior tarsal tunnel. That is the space where the deep peroneal nerve goes underneath the superior extensor retinaculum and the extensor tendons and can actually be compressed and create muscular and painful clinical syndromes. Moving on to the important lateral ligaments that can be seen on an axial image, we can, from proximal to distal, let's evaluate the superior syndesmotic region. In this case, we can see it as thin, low signal wisp bands because it's normal. We can move back and see the interosseous ligament here, this low signal band. Moving up higher, we can appreciate it as it moves towards the interosseous membrane. And of course, the posterior syndesmotic region. And you always want to be cross-referencing so that you can understand where you are anteriorly at the region of the anterior syndesmosis, of course, the interosseous ligament and the interosseous membrane seen more proximally, and of course, the posterior syndesmosis, a very resistant ligament back here. This is your interosseous ligament here. Moving further down from proximal to distal, we have your anterior talofibular ligament clearly seen here. It's comprised of two bundles, and there's arcuate fibers which will connect the lower bundle to the region of the calcaneofibular ligament, which we can see here. The posterior talofibular ligament seen here at the inner aspect of the distal fibula, often seen with striations, which can be normal. In that case, to assess whether or not there's any kind of sprain, I'll be looking toward my T1 weighted images to assess whether or not I have obliteration, which I don't have here, or any kind of fat obliteration signal. But when we can see the bands of the posterior talofibular ligament with the low signal fibers that we can appreciate here and lack of pore distinction, that is a ligament that is normal in signal. So let's getting back to our axial image where we've now evaluated not only the medial flexor tendons and the tarsal tunnel, the flexor retinaculum. We've seen our peroneus longus and brevis and superior peroneal retinaculum. We've appreciated our extensor tendons and the anterior tarsal tunnel. We further went on to look at the ligaments of the anterior lateral side, both the ATFL, PTFL, and the calcaneofibular ligament seen here. We can move now to the medial ligaments. Let's first take a look at the deep deltoid, both the anterior band and the posterior band, slightly thickened here. We can see the region at the origin of the superficial deltoid, and the portion along right at the edge of the curve is where the tibiospring ligament, that portion will go to form a articulation with the supromedial band of spring ligament seen here along the medial talar neck. So that portion of the superficial deltoid moves towards the tibiospring and the supromedial band. We can also appreciate the tibionavicula, which is going to be this band here that's moving from the region of the anterior aspect of the superficial deltoid towards the navicula. And of course, we have the tibiocalcaneal portion moving towards the calcaneus. Furthermore, as we get down to the supromedial band, anteriorly, we can see where that band blends towards the navicula, and then the posterior tibial tendon will attach. And then we can see these fibers here. The supromedial band forms a sling with the medial plantar band and the inferior band to really hold the talar head in place and provide restrictions so that the plantar aspect of the talar head does not move towards the ground, because we want to see that talar head supported by the region of the spring ligament seen in this location here. And in this patient, it happens to be slightly thick even at 13 years old. And we'll take a look at why that is in later sequences. But this is almost normal. Of course, we can see the deep deltoid here slightly thickened, the supromedial band of spring ligament down here slightly thickened, and the tibiospring also slightly thickened. We can appreciate the medial flexor retinaculum on the coronal image. Moving back to our axial image, therefore, we've now cleared our lateral ligaments, we've cleared our medial ligaments, we've looked at the deep deltoid, the superficial deltoid with its three bands, the tibionavicula, the tibiospring, and the tibiocalcaneal. We've moved into the spring ligament where we can see the supromedial spring ligament, the medial plantar band, and the inferior plantar band all holding our talar head. And furthermore, now let's just take a look at what we can see of our Achilles. We can see the Achilles has a nice smiley face, and that's what is normal. We can also appreciate on the medial side an extra decussation, that's your plantaris, moving to attach medially on the medial aspect of the calcaneus. And we can appreciate some of the bands of the plantar fascia, but we'll see those much better in sagittal and coronal planes when we study those next. Are you ready to take your podiatric imaging skills to new heights? Check us out at RadPodSquad.com. Explore our online learning community. And don't forget to like and subscribe to our YouTube channel for more enriching content.